Okay. All right. Good. Good. Well, Josh, thanks for inviting me to this. And by way of introduction, I'm a thrombologist, which is not a recognized specialty, at least in the United States, but for those outside the United States, this is usually a hematologist or internist pulmonologist, and occasionally cardiologists who've developed a deep expertise in thrombotic diseases. So this is what I do. And I've been doing this for about a quarter century, God forbid, it's been that long. My official title is that of Professor of Medicine at the Zucker School of Medicine, Hospital Northwell. I'm also a professor at the Feinstein Institutes for Medical Research and do a lot of thrombosis-related research activities. And then my clinical hat is that of Assistant Director of Anticoagulation and Clinical Thrombosis Service at Northwell Health. So I have a lot of hats, and my understanding is that we have a large audience and at different stages of one's career and interests and schooling. So we have high school students and college students as well as medical students. So I'll try to keep this as uniform as I can. And what I'll be talking about is the coagulopathy of COVID-19 disease. So many of you must have seen in the media in the last at least a month or so that COVID is an extremely what we call thrombogenic disease. So a high propensity for hospitalized COVID patients and especially critically ill COVID patients to develop blood clots, which includes blood clots in the lungs and the legs, PEs and DVTs, pulmonary emboli, deep vein thromboses, but as well as other arterial side thrombotic events such as classic strokes and MIs, myocardial infarctions, heart attacks, etc. So it's an extremely thrombogenic disease. We don't know exactly why that is, but we've made great strides in the last 3 months to figure out what we call thrombogenicity of why patients, especially hospitalized patients with COVID-19, either have a greater propensity to get clots or have a greater propensity to die from clots. So it's a big thing, and as we'll see, about 40% of hospitalized patients with COVID-19 have some evidence of blood clots. So as a thrombologist that's been doing this for a long time, this is the most thrombogenic disease I've ever seen in my lifetime, just to give you all a flavor of what this means. My disclosures, and by way of introduction, we should all by now know the ravages of COVID-19 caused by the SARS-CoV-2 virus. This is quite dated, but again, this is data from over a month ago, over 1.1 million cases, 64,000 deaths, much more elevated now. These are wartime figures, everyone. So we've never seen these, at least in our lifetime, a disease to cause such ravaging implications for healthcare systems. At Northwell, we've touched, I believe, over 70,000 patients with COVID-19, and we've admitted probably over 12 to 13,000 of those patients in our hospital system. So again, these are wartime figures, just to give you a sense of the urgency and the tsunami of COVID-19 in our system. As I mentioned, thrombotic complications have been associated with 40% of COVID-19 associated deaths, especially in patients with underlying cardiovascular disease. So this is a disease with both morbidity but also mortality. And we've known from previous experiences that hospitalized medical patients, including those with pneumonias, are at moderate to high risk of getting thrombotic events. And we can reduce that risk by 50 to 60% using classic agents that we have in our back pockets, namely injectable agents, or what we call parenteral agents, such as classic heparin or low liquid heparin. And we've been doing this for about 20 years. And we also now have recent research coming from really our research efforts at the Feinstein as well as others, that there's a subset of medically ill patients, about a quarter of these patients, that will be at high risk of thrombotic disease, especially in the post-hospital discharge period. And using some of the new oral anticoagulants. They were called novel oral anticoagulants, or NOACs. We now call them the direct oral anticoagulants, or DOACs. And these include agents like rivaroxaban or Xarelto that you may know, or apixaban or Eliquis that you may know. So using these agents, we have the ability to reduce the risk of thrombotic events after someone leaves the hospital, a patient leaves the hospital, by about 30%. Now, interesting enough, we've had previous experiences with viral pneumonias, and especially in the setting of acute respiratory distress syndrome. So these are patients who are critically ill with viral pneumonias. And these pneumonias include MERS and SARS and even H1N1. So you may be familiar with these kinds of previous pneumonias that we've seen. But if we look carefully, we would see that previous viral pneumonias also are associated with a many-fold, over an 18-fold risk of getting thrombotic complications. And we can reduce that risk by giving anticoagulants or blood thinners. We also, as I mentioned, have pretty recent data in the last 10 years or so that the risk of thrombotic disease in hospitalized medically ill patients, including those with pneumonia, extend well beyond hospitalization up to about 45 to even 60 days. So this is, I think, extremely important and relevant in the COVID era. Now, this is a very complex slide, and I'm going to try to simplify this slide. And you can't get away from it. Unfortunately, as a medical student, I remember when I looked at the coagulation system, the first thing I did was fall asleep. But here you have it. You have to know it because at some point it's going to come back to you again and again and again if you're interested in being a physician, and no matter what specialty you choose, but you have to have at least a basic understanding of the coagulation system. But what's unique about viral pneumonias is this phenomenon of what we call cytokine storm and thromboinflammation. So the virus enters the lung, infects the epithelium of the lung. It causes inflammatory changes. And those inflammatory changes subsequently cause cell death. Jay, I'm talking. Can you please? It's my wife. Those inflammatory changes cause an expression of cytokines like interleukins to express themselves in something called a cytokine storm. So this is a kind of a manifold manifestation of a storm by the inflammatory system, the cytokine system, and all that leading to coagulation activation. And as you can see in this slide, the coagulation activation comes from many different sources. One could activate platelets. One could activate what we call the extrinsic part of the coagulation system by activating tissue factor. One could activate the vascular endothelium. And lastly, there's a decreased tendency for what we call fibrinolysis. So the ability for the body to lyse or break down a clot. So there are manifold manifestations of coagulopathy or a disjointed coagulation system in those patients, especially those severe patients with COVID-19 pneumonias. And the final common pathway is that of, as I mentioned, platelet activation, the deposition of fibrin, and the formation of clots, both what we call microvessel clots, so occurring at the juncture of the epithelium of the lung with the capillary of the alveoli, as well as macrovessel disease, so causing large blood clots in the lungs and legs. So this is the concept that we call thromboinflammation. And in terms of risk factors for blood clots in SARS-CoV-2 infected patients, we have the classic risk factors that we've known for a long, long time. So we know that elderly medical patients who are bedridden and come in with an acute, for example, exacerbation of their underlying cardiopulmonary disease are at increased risk of getting blood clots. But also patients with kidney disease or heart failure or malignancy, especially active malignancy, are also at increased risk of getting blood clots. And what's very relevant to COVID is patients who are septic with COVID or other viral pneumonias are also at increased risk of getting thrombotic disease. So we have the classic patient-related risk factors, but on top of those risk factors, there are COVID-19 specific risk factors, namely in the super infected individual that has a hyperinflammatory response and subsequent endothelial dysfunction. And that's seen by lymphopenia, a very elevated response of cytokines, interleukin-6, and other things. And we see evidence of, as I mentioned, microvessel, microthrombotic disease in the lungs, in various blood vessels, and also evidence of myocardial or heart injury by elevated cardiac biomarkers. And we also have other biomarkers such as elevated D-dimers to suggest that there is a coagulopathic process in play. And in terms of clinical outcomes, as I mentioned, these patients are at many-fold elevated risk of getting venous thrombosis or thromboembolism, but as well as other classic arterial side thrombotic complications such as myocardial infarction and strokes. Now, there are certain predictors of getting thrombotic disease in hospitalized COVID patients. As I mentioned, we now know that a certain biomarker that we have, D-dimer, if it's very elevated, that portends a poor prognosis. If a patient is of advanced age, over 75 years of age, that portends a poor prognosis. If they're obese, if they have underlying cardiovascular morbidity, these are all high clinical risk factors for poor outcomes and predictors of thrombosis. If they have sepsis, or if they need mechanical ventilation in the ICU, that's also a predictor of poor complications and thrombotic events. And lastly, the use of treatment dose blood thinners or anticoagulant therapy appears protective in these patients. Now, just so I can introduce this concept to all of you, we now in 2020 have validated clinical risk scores to tell us what grade of risk a patient is for developing venous thromboembolic disease. And one such risk score that we developed in our lab at the Feinstein is something called the Improved Clinical Risk Score. This is a clinical risk score that includes 7 clinical risk factors that are weighted and scored, and depending on the actual score, if patients have a score of 0 to 1, they're at low risk for getting thrombosis. If they have a score of 2 to 3, they're at moderate risk of getting thrombosis. And if they have a score 4 or more, they're at high risk of getting thrombosis. So we use these tools to predict the risk of venous thromboembolic disease, both in hospital, but also in the post-hospital discharge period. And these scores have now been validated, such as the Improved tool. The other thing that's important, and that we recently described this, is the use, as I mentioned, of a previous biomarker, something called a D-dimer, which tells us how active a patient's coagulation system is. And if this D-dimer is greater than 2 times the upper limit of normal, as established by local laboratory criteria, that also as a biomarker that predicts a high risk of thrombotic events in a particular patient, both in the hospital and in the post-hospital discharge setting. Now, as I mentioned, we have a much better sense, in July 2020 of what are some of the unique features of thrombotic events in hospitalized COVID-19 patients. And again, these have been tremendous efforts because we really knew very little as late as February 2020. So we've learned a tremendous amount in the last 4 months of some of these unique features in hospitalized COVID-19 patients to cause thrombotic events. So the first unique feature in these hospitalized COVID-19 patients is the very high prevalence of thrombotic complications. So we have rates of DVT or deep vein thrombosis as high as 85% that have been described in multiple case series in these patients. And the usual rates are in the 25 to 46% range. And the reason for these discrepancies are both because of the patient population. Described the early studies were done in China, subsequent studies were done in Western Europe, and more recent studies were done in the United States. So there are different patient populations, but also different ways in which these various national health systems treat patients. So there's also maybe treatment related differences across these countries and populations as well. But lastly, the other important difference is the use of screening tools such as Doppler ultrasonography versus no screening tools that may also explain some of these huge differences. However, irrespective of the way we slice the pie, we can see that the rates of DVT, but also pulmonary embolism, PEs, that have been described as high as 42%, are threefold higher risk compared to historical matched control. So if you take patients with acute respiratory distress syndrome in the pre-COVID era, and you get their VTE rates, COVID patients with the same type of clinical features have anywhere from a 2 to 10-fold higher risk of thrombosis. And this is quite unusual, and many of us think quite unique to COVID-19. And lastly, the amount of arterial side thrombotic complications is also quite high, approaching 4%. The second feature of thrombosis in COVID-19 patients is their quite unusual nature. So on the left, we see a high resolution CT scan of a patient who's hospitalized with COVID-19 and has a classic both what we call central pulmonary embolism or central lung clot in their left and right pulmonary arteries, but also evidence of subsegmental disease, again, suggesting something called an in situ thrombosis, or where the virus has entered the pulmonary epithelial cells, there is local destruction, local discharge of inflammation leading to hyperinflammation, a cytokine storm, and local thrombosis. Because again, in the pre-COVID era, the vast majority of lung clots or PEs came from the legs. So this was what we call an embolic phenomenon, where clots in the legs, embolized, went through the right side of the heart and showered the lung. And we call this classic, what we call macrovessel thromboembolic disease. But what's unusual in COVID is the fact that in addition to macrovessel disease, there's evidence of microvessel disease and in situ thrombosis, as I explained. And on the bottom, we see the classic ground glass opacifications that we see, especially in seriously ill patients with COVID-19 pneumonia. And on the right, we can see evidence of pulmonary microthrombi with deposition of fibrins seen in the blue stain, as we see here, as well as presence of megakaryocytes, as we see over here as well. So we see evidence of what we call fibrin depositions and pulmonary microthrombi in the pulmonary vasculature. So this in situ phenomenon and the microthrombotic nature of COVID-19 is also quite unique to this disease. And of course, my computer has stopped working. It says the genie here. Let me see if I can get this to work. And of course, I can't get it to work. That's the beauty of the COVID area. And so Joshua, I may have to escape.
Yeah, I was just trying restarting the PowerPoint.
Oh wait, it came through. All right, it actually came through. All right, I'm crossing my fingers that the AV genie is back in the bottle. So, and then the third, I think, quite unique phenomenon about COVID-19 coagulopathy is this phenomenon of breakthrough thrombosis. So despite patients being on standard, what we call thromboprophylaxis or clot preventing medications that we've used for 2 decades, there are still very high rates of thrombosis, about 13 to 27% to as high as 17% in certain patients with acute respiratory distress syndrome. And interesting enough, compared to the non-COVID patients with ARDS, as I mentioned, there's a 6-fold greater risk of thrombotic complications, again, despite using the standard prophylactic anticoagulants that we have. So there's this phenomenon of breakthrough thrombosis that we haven't quite figured out yet as to patients who are hospitalized with COVID-19, especially those who are critically ill and get thrombotic events. And this is quite an interesting thing with many theories as to why this may be, including the phenomenon of heparin resistance, the phenomenon of the cytokine storm causing hyperinflammatory response that may be, some aspects may be resistant to standard anticoagulants, and that if you don't fix the underlying inflammatory and cytokine storm component, you won't reduce the risk of thrombotic events. So a very interesting phenomenon. Now, because of these very unique and very worrisome features of thrombosis in hospitalized COVID-19 patients, what we saw in the last few months was a plethora, a huge influx of international guidance statements on how to manage the thromboembolic complications of hospitalized COVID-19 patients. And I was fortunate enough to chair one of these international guidance statements, that of the International Society of Thrombosis and Hemostasis. And the reason why we call them guidance statements is because we have very low quality data. So none of these statements are based on anything resembling randomized controlled trial data, which is our highest level of evidence. They're based on data from case series or cohort studies, which are the weakest level of evidence. But despite this, we had, again, huge amounts of hospitalized COVID-19 patients, and we had to manage these patients in the hospital. So something, even based on expert opinion or experience, is still better than nothing. So this is why these guidance statements were there, that, waiting for the high quality randomized controlled trial data to come out, we still had to help physicians in their care of hospitalized COVID-19 patients. So we see some of these. I'm not going to go through all of them, but for VTE prevention or prophylaxis, we said that all hospitalized COVID-19 patients should universally obtain thromboprophylaxis with heparin, preferably loam liquid heparin, that we should use in certain patient groups, especially those who are critically ill patients or patients who are obese. We should really switch to intermediate doses of heparin. And especially in critically ill patients, we should consider multimodal thromboprophylaxis, especially with mechanical thromboprophylaxis. That's the first concept. The second concept is that of extended thromboprophylaxis. So in COVID-19 patients who are hospitalized and have high-risk features, we should strongly consider extended prophylaxis after a patient leaves the hospital for up to 30 days with either loam liquid heparin or, as I mentioned, a direct oral anticoagulant such as Xarelto. And lastly, for treatment of thrombotic disease, we should preferably use loam liquid heparin as opposed to any other agent. Now, I'm not going to belabor all of the work that we did with respect to our VTE prophylaxis protocols. Suffice to say that at Northwell Health, we very, very early on developed a universal and systematic approach as to how we should prevent thrombotic complications in our 23 Northwell hospitals. So this was a multidisciplinary effort, but also an effort that involved the leadership, informatics leadership, academic leadership, to come together very quickly to produce these VTE prophylaxis guidelines. And we have here just a flavor of what these VTE prophylaxis guidelines look like. What we said was in patients who are in the intensive care unit, what we did is we developed a much lower than usual threshold for renal insufficiency to give patients a higher heparin exposure. And also, we said that if patients have BMIs over 30, they should also have a higher heparin exposure. So much lower thresholds than we used in the past in terms of renal clearance, as well as BMI or obesity criteria, to use higher doses of heparin and expose patients with higher doses of heparin. And of course, if patients were in the intensive care unit, consideration for using both pharmacological prophylaxis or preventative measures, as well as mechanical measures as well. And this showed our policies and procedures for extended prophylaxis in hospitalized COVID-19 patients. So these were patients who were discharged from the hospital. And what we said is if they have high-risk features, as I mentioned before, an improved score of 4 or more, which puts them in the high-risk category, or if they're over 60 years of age, so advanced age, and have elevated D-dimers, those are patients who we thought would benefit from extended prophylaxis with either low liquid heparin or direct oral anticoagulants such as Xarelto 10 milligrams, which is the preferred agent. If patients have severe renal insufficiency, then maybe other modalities such as baby aspirin could be used. So these were our again, prevention guidelines. So where are we in July 2020 with respect to understanding the thrombotic risk for COVID-19 patients? Well, conceptually, I think we can think of 3 phases of thrombotic risk: the outpatient or pre-hospitalized phase, which we think represents a low risk thrombotic period, although there's some worrisome data that's coming out that in especially elderly patients who are immobile, those patients may have a higher than usual risk of getting thrombotic events. The period of hospitalization, which we now know represents a high thrombotic risk period. And then the post-hospital discharge period, which we think represents an intermediate risk period, although we have no strong data at this point, but data is forthcoming. And remember, we have to think of thrombotic risk as being both patient-related or intrinsic to the patient, as well as COVID-related or disease-specific. So as I mentioned early on, we have to think of the classic patient-related risk factors: obesity, advanced age, immobility, as well as COVID-19 related risk factors, especially elevated D-dimers as a biomarker. And what do we know at this point in 2020? Well, we've established, and other health systems have established, a universal thromboprophylaxis policy. So any hospitalized COVID-19 patient that enters the doors will get some type of pharmacologic prophylaxis unless they're at high risk of bleeding. That's the first thing. And then the second thing, which is a paradigm shift, is suggesting extended prophylaxis, usually with a direct oral anticoagulant, in high-risk COVID patients as they leave the hospital for up to 30 days. Now, that's what we have right now. But I think we need a lot more data on both of those accounts, as well as data in the outpatient period. So is there a subset of outpatients with COVID-19 disease who may benefit from thromboprophylaxis or thrombotic prevention strategies as well? So this is where we are conceptually in July 2020. In terms of antithrombotic strategies, again, this is a complex slide, and I'm going to simplify this. What we should target are 3 aspects of COVID-19 coagulopathy or disease. We should target the inflammation, especially the hyperinflammation that we see in these very severe hospitalized COVID-19 patients. And towards that, we can use either specific agents such as cytokine and IL-6 inhibitors or interleukin-6, which are, again, specific subset of these cytokines. We can use classic agents such as corticosteroids or statins to combat the inflammation, or these are more generalized approaches. So this is one strategy. We should definitely target procoagulant factors in our armamentarium. So we can use the direct oral anticoagulants, specifically the 10A inhibitors, but also direct thrombin inhibitors as well, to target formation of fibrin. We can also think about using antiplatelet agents because, again, thrombin also acts to activate platelets as well. So that could be a consideration. And lastly, we can think about newer agents such as contact activation pathway inhibitors, namely factor 11A inhibitors or factor 12A inhibitors, which are undergoing phase 2 clinical trials as we speak as potential agents to combat the coagulation seen in COVID. And lastly, we can use also natural anticoagulant pathway inhibitors. So our friends heparin, low liquid heparin, which are antithrombin dependent agents, we can use those agents as well. But we can think about new strategies and new approaches such as activated protein C pathway inhibitors or thrombomodulant inhibitors or inducers as well to this. So we see what we call a multi-pronged strategy targeting the inflammation of COVID-19, the coagulation of COVID-19, targeting natural procoagulant factors, and of course, natural anticoagulant pathways as well. But I think the most important clinical question we have as clinicians is this one here shown in this slide. Is the concept of exposure to escalated or treatment dose of anticoagulant therapy, would that have potential to decrease the coagulopathy seen in severe or critically ill COVID-19 patients? So we have some data to suggest that in patients with high-risk features, such as those with elevated D-dimers, as I mentioned, greater than 6 times the upper limit of normal, or in some cases 4 times the upper limit of normal, or in those patients who have evidence of sepsis using validated sepsis scores, such as the SIC score, there is evidence that in those patients who use heparin, there's a mortality advantage over heparin non-users. But I think that's really not the key question in my view, because in our hospital systems at this point, all patients are receiving heparin. The real key is seen here, is the use of therapeutic heparin as thromboprophylaxis or as a preventive strategy. Does that reduce hospital-based thromboembolic complications? And we do have some early data to suggest that in those patients who receive treatment doses of heparin, there was a 70% reduction in thrombotic complications versus those that received standard dose heparin therapies. And again, the mechanisms of dampening COVID-associated coagulopathy using an agent like low liquid heparin, you may know this as enoxaparin as medical students. So an agent like enoxaparin not only has the possibility of preventing thromboembolic disease, specifically venous thromboembolic disease, but it may have off-target or what we call pleiotropic effects as well. So in theory, especially at treatment doses, it may potentially suppress the development of cytokine storm in these patients. And there's data that it may competitively bind to coronavirus rather than heparin sulfate. So it may have multiple off-target effects in addition to the classic anticoagulant effects seen with administrating this low liquid heparin. So towards this end, there have been now both nationally as well as internationally, the initiation of multiple randomized trials of escalated or treatment dose heparin in hospitalized COVID-19 patients. And these are some of the key trials that you see here. Our own trial is called the COVID trial that we've initiated via the Feinstein Institutes for Medical Research a few months ago. And these all are key, again, key clinical trials in the area of COVID-19 and thrombosis. And this tells us the clinical trial design of HepCOVID. I'm not going to bore you with the specifics. I'm a clinical trialist at heart, and that's what I've been doing for 2 decades. So I love doing this kind of thing. I love designing high quality but pragmatic trials that can help answer the question. And of those of you who are interested in this, again, in many ways, as a surgeon, I think in some ways clinical trialists are born as well as made. So academically, as students, if you're interested in these kind of clinical questions, you may have what it takes to be a clinical trialist. But this is a very long road. You have to have lots of patience. Some of these trials take a decade to complete. And they're fraught with misadventures, they're fraught with headaches, they're fraught with dead ends, and they're fraught with negative data. So again, you may get positive data 10 or 20% of the time, so you should be aware of that. But even with negative data, you've actually helped to answer the question as well. So it's what you do in victory as well as what you do in defeat that helps you along as a clinical trialist. But anyway, this is the COVID trial. Again, I'm not going to go into details, but these are the entry criteria, or what we call the inclusion criteria. Patients have to be sick, very sick with and hospitalized with COVID-19 pneumonia, high-risk features such as elevated D-dimers. They're randomized in 2 strata, whether they're in the ICU or not in the ICU, and they're randomized to 2 treatment arms, either treatment dose enoxaparin, which is a low liquid heparin, or standard of care heparin using prophylactic or intermediate doses. All patients will get a day 10 ultrasound of the legs using a Doppler compression ultrasonography, and there's a 30-day follow-up. Again, usual exclusionary criteria. The primary efficacy endpoint of the trial is a composite of total thrombotic events, including arterial as well as venous thromboembolic events, and all-cause mortality on day 30. And the principal safety endpoint is major bleeding. So in every clinical trial, you have to have an efficacy endpoint, and you have to have a safety endpoint of similar clinical severity and similar clinical weighting. And this just represents on the bottom right our statistical assumptions for the trial. We're assuming a 40% risk reduction and an incidence of 42% in the control group of a primary efficacy endpoint. So we need about 308 patients to do this trial. So this gives us a flavor of what I think a well-designed randomized trials will look like. And hopefully this trial is ongoing. It's multi-center. It's now a national level trial. And hopefully by April 2021, we'll have the answers. So there are other ongoing clinical research in the setting of COVID-19 and coagulopathy. One question is the use of systemic TPA, which is a thrombolytic agent. Can the use of systemic TPA reduce the hypoxemia and ARDS associated with severe COVID-19 infection? So there's a study called the STARS study, which is a phase 2A study, a safety study to assess systemic TPA in this setting. As I mentioned, there's a whole slew of potential targeted activities, both to immunomodulatory agents, also targeting contact pathway inhibitors, hemostatic modulators, and antiplatelet, as well as dual pathway inhibitors. So these are potential or again, intellectually and academically interesting targets to think about. Can we target interleukin-1 or interleukin-6 or something called JAK modulators? Is there a role of contact pathway inhibitors, such as I mentioned before, factor 11 and factor 12A inhibitors in again, severely ill COVID-19 patients? Is there a role of antiplatelet agents with or without low doses of anticoagulants as part of what we call dual pathway inhibitors, which inhibit both the antiplatelet pathways as well as the classic coagulation pathways? Is there a role of hemostatic modulating agents? And I mentioned the role of activated protein C inhibitors as well as thrombomodulants. So these are all, I think, again, intellectually interesting potential targets in the future. And maybe when you all become research scientists, you can, again, answer these critical questions. As I mentioned before, one of the other, I think, big clinical questions in the field of COVID-19 and thrombosis is that of a potential role of primary thromboprophylaxis in sick outpatients. So these are what we think are outpatients who've never been hospitalized but have very high-risk features. Again, advanced age or elderly patients with immobility and cardiopulmonary disease. This is an example of what we think is a potentially high-risk patient. And in those patients, are there advantages of giving them prophylactic anticoagulants, especially low-dose anticoagulants such as enoxaparin or Xarelto at low doses, 10 milligrams, before they ever enter the hospital, so as to prevent hospitalization and to prevent outpatient-based thrombotic events. So this is, I think, a very interesting clinical question. And there's a large trial that I'm involved with, Prevent HD, about the 4,000 to 5,000 patient trial that is hoping to answer this question as well. So again, a lot of research activity both in the hospital setting as well as in the pre-hospital or outpatient setting as well. So this is my next to last slide. I hope to have given you a flavor of the nature and complications of thrombotic disease in hospitalized COVID-19 patients. Hospitalized COVID-19 patients, as we see, appear to be at very high risk of getting thrombotic events, especially in patients with critical illness. There's this unique phenomenon of in situ PE or pulmonary embolus that occurs at the level of the lung without any embolic embolization from the legs. And this causes microthrombi to form. There's this phenomenon of breakthrough thrombosis despite standard thromboprophylaxis. And though we don't have definitive data, we think that a subset of these COVID-19 patients are likely at risk for getting post-discharge thrombotic events and may benefit from post-discharge thromboprophylaxis. In terms of the recent guidance statements from many international and national societies, there's the, again, advocacy of the use of universal thromboprophylaxis, especially with low molecular heparin, for every COVID-19 patients that enters the door of the hospital, with a modified dose to using intermediate dose heparin, especially in those patients who are obese or are critically ill. And again, the use of extended thromboprophylaxis in these hospitalized patients with high-risk features for up to 30 days. So some of the future considerations, as I mentioned, are the use of randomized controlled trials comparing treatment dose versus prophylactic intermediate dose heparin for primary prevention in hospitalized COVID-19 patients. So there's a lot of research activity going on in hospitalized COVID-19 patients to answer this question. We need also high quality data from hospital post-discharge data from registries to answer the question of what is the thrombotic risk, not just in the hospital, but after a patient leaves the hospital, let's say in the first 60 or 90 days after they leave the hospital. And as I mentioned, there's ongoing clinical trials of primary prophylaxis in outpatients with the COVID-19 that have high risk features. So there's a lot of clinical trial activity in the world of thrombosis in this population. And this is my last slide. These are some of the future antithrombotic strategies in patients with COVID-19 disease throughout all of the spectrum of their disease, whether they're simply exposed but don't have high-risk features, in an asymptomatic patient who is tested positive, which by the way, I was very early on. I was, I developed COVID-19 in March. And luckily for me, I was essentially an asymptomatic patient with some of the potential recommendations and drugs to use. Whether I would have benefited from low-dose aspirin, we don't know that answer, but luckily I recovered fully. Also, COVID-19 patients who have high-risk features but being managed as outpatients, whether again there's a role for using a direct oral anticoagulant or aspirin therapy or both. And of course, other modalities such as the use of anti-inflammatories in those patients. For those patients who are hospitalized with COVID-19, I mentioned the concept of universal prophylaxis. I mentioned the use of heparin, preferably low liquid heparin in these patients. And again, these patients are being studied whether they would benefit from escalated or even treatment dose heparin in terms of preventing thrombotic complications. But we can also look at other types of therapeutic modalities, such as the use of thrombomodulant or antithrombin and other, again, anti-inflammatory agents as well. For the critically ill COVID-19 patients, this is a very special patient population at extremely high risk of getting thrombotic events. And I think this is really the key target population for the various escalated heparin randomized clinical trials that I introduced to all of you. Also, the use of fibrinolytic therapy should be specifically studied, in those patients, as well as other therapeutic modalities, antithrombin, the use of thrombomodulant, and the potential use of activated protein C as well as anti-inflammatories and antiviral agents. And lastly, the post-discharge period. This is another area of potential research, and I mentioned the need for developing both policies, procedures, but also research activity in trying to define which of these hospitalized COVID-19 patients have high-risk features for getting thrombotic events after they leave the hospital, especially in those first 30 to 60 days, and can we prevent thrombotic events safely by using various anticoagulant strategies. So that's what I have, folks. And with that, I hope to have at least introduced to you the path to COVID VTE enlightenment. Thank you.
If you want, I'll open up the chat function for some questions because we have 12 minutes left. I'll stop sharing for you.
Sure. Maybe, Joshua, if you could tell me some of the questions, because again, for some reason, my computer's acting up again.
Yeah. I'll just start at the top. So first question is, how do COVID's interactions with ACE receptors lead to cytokine storms?
It's an excellent question. It's more than I can answer in a few minutes here. And again, in deference to our audience, I won't be too specific, but the key here is the ACE2 is the mechanism or vehicle by which the SARS-CoV-2 virus enters the pulmonary epithelium. It causes then netosis and causes death in these cells, which then cause local inflammation, which ultimately induce hyperinflammation, and in a subset of patients, as I mentioned, severe hyperinflammation, endothelial dysfunction, as well as cytokine storm. So, and that ultimately activates the coagulation system. As I mentioned, this is multi-level, both at the level of platelet activation, at the level of endothelial activation, at the level of extrinsic pathway activation, and contact pathway activation as well as a decrease in fibrinolysis.
All right, we have some more.
Mm-hmm.
I guess this is very important now, which is, as a college student, what resources would you recommend to keep up with newly released studies and articles about COVID-19?
Yeah, that's a very, very good question. So there are some what I would suggest you all do is go to the various guidance statements that I mentioned in my discussion. So the journal Thrombosis and Hemostasis has a guidance statement, which I was fortunate enough to be the lead author, was published a month ago. And within that guidance statement, the beauty is that you have a plethora of references, right? So the guidance statement really takes and synthesizes all of the key clinical questions into a nice document. So that's one guidance statement. Another guidance statement that I mentioned in my discussion is that by Bigdelli et al. In the Journal of the American College of Cardiology, or JACC, and that's another very good guidance statement. Thirdly, there's a very nice review of antithrombotic strategies by the same lead author, Bigdelli, in Thrombosis Hemostasis. I would look at that as well. And lastly, there's a very nice guidance statement by Chest that was published by Moores et al., M-O-O-R-E-S. That was last month as well, and I would go there as well. And again, all these guidance statements not just provide guidance, but synthesize the existing literature and talk about future strategies.
I think we lost your video. Do you want to try to turn your video on and off again?
Okay. Did you, were you able to hear what I said?
Yeah, we hear you still.
All right. Well, maybe I won't touch anything, Josh, because I'm scared with, I'm scared with my computer, whether it, for some reason, it's really acting up.
All right, let's see some more.
Yeah.
A lot of people are asking about just thoughts on the new vaccine, on Moderna vaccine, just a lot of vaccine questions in general.
Yeah, I mean, I think, you know, the vaccine, and again, I'm not an infectious disease specialist, so you're hearing it from my perspective. I think the vaccine may be helpful, but it's not the panacea that we think it will be, okay? We don't know how long, first of all, we don't know if it will be effective. Again, the difficulty of SARS-CoV-2, it's a coronavirus and it's a respiratory coronavirus. So the rates of mutation, the distribution of the virus, the inhalation of the virus, all this makes it very difficult to develop, a stable vaccine. Even if we do develop a stable vaccine, again, will it be stable over the course of the virus, or will there be lethal mutations of the virus that will need, again, multiple vaccinations in patients? So we don't know that answer. Number 4, it will take a much longer time frame for the vaccine, I think, to be ready for prime time. I think we've underestimated the time frame. So I think the vaccine is something we should see in the long-term horizon, but in the short-term horizon, I think we have to think about specific measures such as IL-1, IL-6 inhibitors, inhibitors of the inflammatory response, generalized agents such as the use of steroids, and specific coagulation targets, as I mentioned. These are all things we could do in the short and intermediate term, and I think we will need to do that before we see the vaccine.
Awesome. All right, we have one here. For how long do COVID patients have to be on blood thinners post-recovery?
Excellent question. So in those patients who have been hospitalized but don't have high-risk features, again, they don't have advanced age, they don't have very elevated D-dimers, they don't have underlying cardiovascular or cardiopulmonary disease, we think that they should get prophylaxis while they're hospitalized. But if patients have high-risk features, and I mentioned those already, those are the patients who should get prophylaxis both in the hospital, but up to about 30 to 45 days after they leave the hospital as well. And lastly, we think there's a subset of outpatients with COVID-19 disease who have high-risk features, again, advanced age or very elevated D-dimers or underlying cardiopulmonary, cardiovascular disease. With immobility, we think that these patients may also benefit before they even come to the hospital by getting thromboprophylaxis at home as well.
Just looking for some more. We got a lot of questions coming in.
Yeah.
Would targeting the NF-kappa B pathway ease CCK storm effects?
Yeah, can I ask the attendee to speak in English? So that, is it the natural killer cell, or what is the NFK pathway?
We'll have them reword their question.
Yeah. So speaking, again, folks, because I think we have a lot of, participants here with a wide range, probably it's better if we keep this as general as possible, thinking about concept rather than specific pathways. That's what I hope to have done anyway.
Someone asked just what made you choose your specialty?
Yeah, it's interesting. I hated blood, so I never thought I would be into blood. I thought I'd be an epidemiologist. And as I moved on in medical school and as I moved on through my internship and residency, I became fascinated with rheumatology, and I became fascinated with the coagulation cascade. So intellectually, I was drawn to this. And then number 2, when I was a hospitalist 25 years ago, the chief of hematology tasked me to develop an outpatient DVT program, which in 1995 was extremely rare. And I remember my hematology colleague said, Spyropoulos, you treat these patients with an acute blood clot in the outpatient setting, we're going to sue you because it can't be done with this drug called Lovenox that you can't even monitor, right? So very early on, because of I guess, prodding from outside hematologists, I learned to do scientific research. So I started my career being an outcomes researcher first, and then I went on to become, as I mentioned, a clinical trialist. And now I love what I do.
Someone said, based on your clinical experience, what is the chance for long-term increased risk for clot formation post-COVID-19?
No, great question. And to the best of our abilities, we think that the risk for getting thrombotic complications in COVID is fairly short-lived. So the phenomenon of immunothrombosis is literally like a tsunami. You know, it comes over, it overwhelms the body, but just as quickly it leaves the body. And the way we know that is when we look at serial inflammatory and coagulation markers such as ferritin or procalcitonin or CRPs or D-dimers, we see that, you know, they're low, they get extremely elevated, and by, let's say, 3 months, they're normal again. So we think this is a fairly transient phenomenon in the vast majority of patients. Now, we can't exclude that in a small subset of patients, they may have chronic complications. And indeed, you know, vasculitic phenomenon have been described, Kawasaki-like vasculitic phenomena have been described, especially in pediatric patient populations, but we really have not seen these in adult patient populations. So to the best of our knowledge, we think this is a fairly short-lived thrombotic risk phenomenon.
All right, I think we're gonna stop you here. I'm just gonna make like one last announcement for everyone. Just a reminder, at 4 p.m. tonight, we have the cerebrovascular webinar, and that will be found on the Instagram page, the Lenox Hill Neurosurgery Instagram page, so you can check that out tonight. Thank you all for coming. Thank you for speaking. If you'd like to say anything else. No,
I just want to wish you all the best in your future pathways and future careers. And the only thing I have to say is do what you love to do. Because if you do what you love to do as opposed to what you're supposed to do, you'll be happy with what you do for the rest of your life.
Thank you so much. Have a great day, everybody.
Bye-bye.